Good morning, everybody. Welcome to Transform. So I'm going to pivot a little bit, and I'm going to share a little bit of vulnerability with the group. We're here to talk about social determinants of health, and I think it's appropriate to share a little bit about my personal story and why I am relentlessly serious and laser focused on homelessness, addiction, folks who have recently been released from incarceration, foster youth aging out, and why I find myself in a Fortune 5 company, moving funds from this large organization back into the community to help the populations I just mentioned. So I came to the United States with my family in 1985. I'm a first-generation immigrant. And it was interesting. We came here on a business visa. It allowed my dad to operate his business, but we couldn't work, and we really didn't have access to a lot of basic resources. One of those resources was healthcare. So I lived most of my childhood in the United States, in Minneapolis, not too far here from Rochester. Never really having much of an experience with healthcare. Didn't have encounters with many doctors or nurses. A lot of the coaching that I got from my parents was, don't get hurt, because if you do, we don't have any way to pay for that. A lot of my life was lived in situations of being precariously housed, right? So really living in apartments, but not knowing where we were gonna be day to day. My immigration status didn't allow me to be very stable. I wasn't sure if we were gonna be in the country or if we would have to move back. It was interesting to watch a lot of my friends take a lot of that for granted. Things like being able to get their first job. I wasn't able to do that. Getting a driver's license and buying a car. Really envious of all of that. So interestingly, what ended up happening was, based on the nursing shortage and some trials and tribulations within my family, things like alcoholism and divorce, my mom went through school as a single mom on very limited income and status, and became a registered nurse. I used to join my mom going to community college. She couldn't leave me at home, I was too young, so I'd roam the halls of Normandale Community College. I'd be in the back of the lecture hall and watched her go through that process, ultimately contributing to high quality care in the United States. Kind of ironic, right? So this person who really didn't have much was able to start giving back to the community. I followed in my mom's footsteps. I actually went through that same community college program when I had the chance to be able to go to college, which to me was a far cry. Some of the instructors actually even remembered me. So I tell you this story because I want you to understand that I'm mission driven, right? I'm dedicated to this cause, but not because I'm seeing what's happening around me in present tense, but I've lived through this. So I'm going to tell you a little bit about what we're doing at UnitedHealthcare, in relation to social determinants of health, and how we are effectively aiming to end poverty, starting one person at a time, one patient at a time. So I'm going to tell you a little bit about things you probably already know, but what we know about healthcare outcomes is that 40% of our health is actually impacted by social and economic factors. Things like housing, job security, nutrition, and basic physical safety. We also have to take into consideration health behaviors, physical environment, and clinical care, right? In this country, we've done a really good job of focusing in on clinical care, but haven't paid as much attention to the social factors. We're starting to do that. So just a really basic overview of what happens with folks, and these are from my real world experiences. Individuals like myself run into a situation where they may get hurt, right? Just like my story, a kid gets hurt, or a person like my mom loses their job. They lose their ability to be financially stable. It creates emotional stress, and it can lead to homelessness. These things also lead to addiction. So we talk a lot about the opioid epidemic, but when we look at the underlying factors and the stories that are actually leading to the challenges, it is stories very similar to my own. Our social system is completely fragmented. So again, thinking about my own background, but then what I've come to learn through my work, people are unable to find their way to basic social services, things that they may even be entitled to. Even if they can find their way, the systems are so complex that navigating is extremely challenging. This ultimately leads to increased ER utilization, increased cost, and poor outcomes from a health standpoint. So what does this all amount to? David had mentioned the number of $1 trillion in annual spend. Well, here's some statistics around that. So for the Medicaid and complex populations, it's about $500 billion, or $500 billion, $500 billion. And for social services, we're spending another $500 billion. So I wanted to bring some really fresh data for you guys and talk to you a little bit about what I've come to understand by utilizing what I would argue to be the largest healthcare data set in the United States through a public firm, UnitedHealth Group. So this is some data coming out of claims. So there's a ICD-10 code, Z59.0. It's a homelessness code. You may be familiar. And what I did was I used our Medicaid book of business. We insure about 7 million Medicaid lives around the country. And I extracted all of the Z59.0 codes out of that data set. So what I came to find, so we have 6.7 million roughly Medicaid covered lives. And I found about 21,000 folks who within the last 12 months had the homelessness code attached to them. So I was really interested. I'm like, okay, so we're spending on an annual basis $413 million on this population of 21. And I will tell you that this number is highly underreported. We know a lot of providers are not using the codes diligently. It's a non-reimbursable code. We all know how busy providers are. So then I zoomed in a little bit more and I'm like, I'm really interested in the top 500. What if I were to create a campaign and filter money in and just target the top 500 within that population? So if we look at the bell curve on the top, that's the full 21,000 people that I identified, and that little tiny red tip on the end are the 500 people that I was most interested in targeting, right? Because you probably heard this statistic of 5% of the population spending 50% of the Medicaid dollars. I came to find that 500 people are going to the ER on average 20 times more than your average Medicaid recipient and over 4 times more than your average homeless Medicaid recipient. And their paid per a member per a month rate reflects that as well. In total, that group of 500 that I identified is spending $81 million per a year. That was the beginning of the business case that I created for UnitedHealth Group to say, we need to do something about this population. We need to start with housing. So we created a new approach. This approach is not just housing-based. We've started with housing, but we've developed a new and innovative socio-clinical operating model, a complete redesign in the way we think about how we deliver care to these patients. These patients, in studying the cases, have been fired from their doctors. They've been prescribed medications that hurt them. They've been yelled at in waiting rooms. And they've been put in places of significant challenge. We started to streamline things. So we started to look specifically at things like underemployment and unemployment. But we moved beyond that because we understand that the traumas that this population have faced don't enable them to just simply reintegrate into the workforce. We need to start thinking about things from a sense of purpose. So we're helping this population as we work with them to find their sense of purpose rather than saying you need to go get a job. We're looking at their housing, and we're actually providing permanent supportive housing with wraparound trauma-informed services. We're looking at ways to help them to get banked, augmented transportation using innovations like Uber and Lyft, and we're basically streamlining an extremely fragmented social support system. We're helping individuals and families, and ultimately we're helping to revitalize neighborhoods and communities through this effort. We're doing it all over the country. These are some pictures, and actually David had mentioned one of our projects in Phoenix, Arizona. So these are real pictures of some of the units. We believe in dignified housing, right? So I talked about a sense of purpose. We know projects don't work, and David, I think, had mentioned that as well. We want folks to feel like they're integrated in society and have a place at the table. So as you can see, I personally take pride in visiting these locations, and I simply judge it by whether or not I would feel comfortable living there with my own family. This is a little bit more about our socio-clinical model. So this looks at not only thinking about identification of the individuals using our robust network of providers, ERs, and hospitals, meeting people at the bedside and helping to support them into the housing, and then engaging care coordination, stabilizing them, and helping them with their traumas, looking at things like really elite behavioral health services, dialectical behavioral therapy, for example, and then also social service coordination, getting them attached to their entitlements. Things as basic as getting a driver's license, getting a social security card, and then finding their way to the social security income or social security disability income that they're entitled to, but they can't find their way to it. Rather than starting with, we need to, up, your insulin because your diabetes is out of control, we start to really look at the social situation first and then move towards the clinical. So some more real pictures. We've got a very innovative way of doing this. We've created a toolbox approach to housing. So we have in the upper box, A, we have our single site model. That's where we've got 500 units, and 100 of those units are dedicated to our patients. So it's integrated within a society or a community where we have folks who are paying full market rate mixed in with our subsidized housing. The second one, B, is an example that we're doing in Las Vegas in partnership with HUD, where we're actually, we have about 100 units scattered across 25 different locations. And this provides a lot of unique benefits, and there's a lot of literature around single and scattered site models, but we've got both within our portfolio. And then finally, we've started a model where we actually bring folks together into a single family home. We're using things like peer-based support and counseling and guidance on site. So depending on the need of the individual, we can find the right type of housing to support them. We've actually created a continuum within our model. So I talked a little bit about the housing, but we've blended that with really innovative approaches to delivering care for populations that typically, they just simply don't fit the mold for the way we do business today within health. We're looking at things like ACEs, so adverse childhood experiences. I told you a little bit about my childhood. There was plenty of adverse experiences that happened. I talked about the alcoholism and divorce, some of the other trauma. We're looking at harm reduction models, connecting folks with MAT at the point of engagement. So as folks are going into jails or hospitals and then having their withdrawals and then being discharged back onto the street and taking the same dose of heroin or opioids that they were taking prior to going into jail or the hospital, and then ultimately resulting in overdose, right? We're looking at being able to connect them with MAT right at the point of interaction. We're looking at the trauma triangle, the victim, the rescuer, and the persecutor, thinking about how these interactions play into their life and how they've experienced the health system. And we're looking at dialectical behavioral therapy. We work hand in hand with a group called the Camden Coalition, led by a gentleman by the name of Jeffrey Brenner, Dr. Brenner, who's come to work for us at UnitedHealthcare. So we've invested in top leaders in this field. So we're proud of a lot of different things. I'm proud of the work, I'm proud of the teams, I'm proud of our partners. I'm proud of being able to make a difference, and I'm proud of being able to use my background as a point of pivot to help this country. Although I'm a first-generation immigrant, and I would argue most of the folks in this room are all first-generation immigrants. We may not think of it that way. I'm proud to be able to take my story and apply it to my work. So this is relatively new data, but I just want to show you a little bit about what we're starting to see with our work. So here I've got two distinct projects. We've got our Arizona project, talked a little bit about that, and our Nevada project. So what happens when you put folks who are formerly homeless into housing and wrap them with truly trauma-informed care? Well, we see that we've got a 42% reduction in Arizona, and in Nevada, even more grand, at 70% reduction in total cost of care PMPM. So if we apply that percentage, that savings, to my 500 top patient bogey, which was $81 million per year in spend, we have the potential to generate almost a $50 million savings annually through this work. And that's just the tip of the iceberg. Pretty interesting stuff as we start to look at it more carefully. So I'm going to leave you with a real case. So this is TJ. TJ was actually a top 10 utilizer in the United States, not in a single market or a single city. Looked at the entire panel of the 21,000 folks that we had identified. Then I looked beyond that, and I looked at the full 7 million Medicaid recipients, and TJ was at the very top. TJ went to the ER hundreds of times a year. His spend was in the hundreds of thousands of dollars per year. The bar graph at the bottom is actually showing all of TJ's utilization. So the blue lines represent his times going to the ER. The numbers at the bottom are days since intervention. And the red lines are actually the inpatient stays. And then you can see there that where it says 158, that's the date of intervention. That's the date that we actually started to engage TJ. And you can see the sharp drop in TJ's utilization. Really proud of TJ's case because he was able to move from not only being housed, but actually move into volunteerism. We found out that TJ really appreciates animals and pets, but could never have one because he was living on the street. So we found him a role in a shelter, in a pet shelter, and then TJ became a peer model for us and is actually working with some of the other patients that we've housed. So TJ's found some purpose, and he's starting to really have better health as part of that. He's starting to care for himself, which is a very important part of this story as well. So I'm going to close with that story, but I hope that the blend of both some of the qualitative data as well as the quantitative data that I shared with you guys was meaningful. So thanks. Enjoy Transform.
Thank you.